Yes, we can.
Okay, great.
Yes.
I got no catchy music for you. Sorry.
Yeah, no catchy music. I think Daw's been quite busy recently, but we'll hope to have him back soon to assist us. Um, as things have turned out, um, the Democratic base and the operative community in the DNC here, of which John is a large part, very significant part in northeastern Pennsylvania, along with some of my other friends, energized by the results of the election and are probably getting ready to start to do their thing in terms of policy recommendations and things again that will move in the direction that we hope that our activist friends who have been somewhat sidelined over the last 4 years will now be reactivated to work on LGBTQ issues that John has been a pioneer leader and community organizer for our area for at least I've known him for 2 decades, and others who have been working on school, education, healthcare, and other issues that it does take community organizers, it takes activists, it takes people at the grassroots and ground level to percolate up the unaddressed issues throughout their communities upward to policymakers and operatives, political operatives, who then craft legislation that eventually makes it to the floor of state legislators and onto the desk of governors. Well, John Daw and a number of his friends and my friends are active in the Pennsylvania community of activists and leaders. And so we wish John Godspeed and renewed energy, and that all of the harm that has been done over the last 4 years to his community, that he can begin to repair. So that being said, here is the usual my personal page, of which I am currently banned. That will end next week. The professional page, which Terry has dutifully been maintaining and cross-posting my Twitter posts to. I've been trying to stay abreast of what's going on in the medical community. Med Twitter is very different than Med Facebook. I'm a nobody there, but I've been trying to connect with people and try to get an idea of who's working on what, and trying to shoulder myself into that community of voices on Twitter in the medical community that's fighting COVID. And then, of course, the evidence page and the YouTube page where these are always published. So moving on, we're in the midst of a massive third wave. This is seeing peaks of daily positivity that far surpass even my predictions or expectations. I posted on Twitter that this has been astounding to look at the models that have been showing what could happen in a third wave. Predictions of a winter where we would see at least twice the caseloads that we saw in the first or second wave, but now we've surpassed 3 and 4 times that caseload. Deaths are on the rise, as are hospitalizations. We have now the highest number of hospitalized patients with COVID ever in the pandemic, and that number continues to rise. The Midwest continues to be a major hotspot, although, as I've said before, a hotspot is geographically generally geographically a small location, but here in the United States, we've redefined hotspot, and it is anticipated that the entire country could become, technically by epidemiological terms, a hotspot wherein we have more than 10% positivity in more than 90% of our communities and 90% of our counties by the time we hit the middle of this third wave. So at 10% positivity, and of course others have talked about using surrogates like number of active cases per 100,000 population, or number of the positive cases detected per million population. Most of us continue to use the percentage positivity rate as a proxy for the severity of the pandemic in a community. So I'll just spend a minute on that. My mind is a bit scattered as I talk through these topics. So if there's any questions, as usual, please stop me or use the chat window to make Terry aware that you'd like to ask the question, or just go ahead and ask the question in chat. But to keep this conversational, always feel free to just jump in and ask me live. So what I was going to say is that the proxy that I just described, it's, the short acronym is PPR, percentage positivity rate. It's best to keep a percentage positivity rate of 1% or below. That gives your healthcare resources, in a community, the opportunity to suppress and contact trace and mitigate and even predict to a great deal a geography that may be experiencing new cases, so that that geography can be reduced down to a zip code level and addressed in a highly effective and specific way. When your percentage positivity rises above 2%, things start to become much more difficult in the contact tracing and suppression and mitigation arena. And once you achieve 5% positivity, you can now say that you have lost control of the transmission. And therefore, at this point, this should be an alarm bell for public health officials in the locality to enact stricter non-pharmaceutical intervention, such as the closure or partial closure of certain businesses, such as restaurants, or restrictions on indoor activities like in gyms, or any place that people will gather. More than 8 to 10 or 15 people will gather in a single room. It should be highly restricted in the event that a locality sees above 5% PPR. If you then achieve 10% PPR, it is a threshold for a lockdown. Now, these are general rules of thumb from an epidemiological and public health perspective. They have not been nationalized. They are not part of a national response strategy. And because of that, we are seeing a massive failure, because as Terry and I were discussing before we started, every state has its own way of going about addressing or not addressing the pandemic. Those states and localities that are not paying attention to these numbers and not using PPR as a proxy and not implementing NPIs at these various thresholds, 1, 2, 5, and 10%, are just basically letting this pandemic rip through their communities, kill people, devastate their economy, their local economies. There is no check on whether their schools are niduses of infection, because children may be asymptomatic carriers, and when they are entering an environment, even when they're masked, but they are in duration, they're in contact with other children for a long duration. We're talking about 4 to 6 hours in a school setting. They actually, with a mask, may be able to contract and spread the virus and continue to be asymptomatic even after 14 days of exposure, even though they are going home and spreading it to their families. So these are all potential theories and reasons for why we are now seeing this massive outbreak. We're seeing that as a result of the schools being open, and I don't know. I generally have stopped checking to see which states and which locations are allowing children to go and attend school without a mask, or are not enforcing the mask rule when the children are not together in a classroom. Which means all the stuff we talked about during our special school town hall, where kids will wear a mask for 45 minutes in the classroom, then they'll go out into the hallway, take off the mask, and walk around each other into the next classroom, completely defeating the entire purpose of having to wear a mask in the classroom. This is apparently happening throughout the country, and this could be another reason that 6, 8, 10 weeks after the start of school, as a result of a lot more people doing a lot more activities indoors, we're seeing that we're having a massive third wave. So kids could be involved. The other thing that could be involved is that a mutation, as of yet undetermined, as of yet elucidated by molecular biology, as we did in the middle of the summer with the D614 mutation, conformational change in the shape of the spike protein that allowed it to transmit more, it became stickier. It was able to transmit during the summer months more readily in the southern states, and we had a big outbreak in Texas and Louisiana and Arkansas and all of the southern states, Mississippi, Alabama, Florida. We may be seeing a conformational or a morphological change in the virus. Mike Kidd, our stats and numbers guy, I call him the Oracle, responded to a tweet earlier this week that says that told me that someone out of Spain has detected a Spanish variant that is now becoming prominent in the EU and the UK, and therefore we also may actually have a new strain on our hands that we haven't elucidated yet, that's making it much more transmissible and causing these numbers to just explode on us. And I guess a few months from now we will know, or a few weeks from now, I hope. I don't really have much to say about the election. If anyone has any opinions, I'm glad, obviously, I'm glad for the outcome. And I'm speaking not personally, but professionally, and from the perspective of someone that's trying to do, the evidence-based dissemination of public health recommendations. Clearly, this administration has been a massive failure. And the post-election period of the lack of, cooperation with the new incoming administration is going to delay a lot of vital processes till after the inauguration. And instead of trying to, be collegial about adopting what will be the new pandemic response after January 20th, we're just going to see the same pandemic lack of response for the next 65 days. So the federal response is at 0 right now. And I'm hearing from all over the country that there is now a increasing concern about PPE in hospital and clinical settings, that 7-day reserves have now been whittled down to 3-day reserves, that soon those 3-day reserves at the current caseload will be down to rationing. And again, nurses and doctors having to reuse critical equipment because they just don't have enough to use fresh equipment. And that's going to change the dynamics of how patients are treated. It's going to result in more death, more destruction, lower quality and safety thresholds for patients who end up in hospitals. When you have that happen, people die, because going into a hospital is not a mechanistic process. Going into a hospital require the outcome for the outcome of going into a hospital to be positive. You want the people in that hospital to be well rested, well supplied, attentive, and basically at the top of their game, so that the care that you receive is at a standard that is puts you on a trajectory for a positive outcome, a short stay, and a fast recovery. If
Hey,
you are,
Sanjay.
yeah,
Yeah, I just wanted to say that, a lot of people look to these new treatments they have and how the people respond better to them. And the only thing I could think of is you have to actually be able to get into the fucking hospital to get it.
yes, yeah,
So if the hospital has people waiting 6 deep in the hallway, not even in the ER or in a room, okay, your chance of getting that life-saving, like maybe something like the president got, you know, you're not going to get it. You're not going to get A plus treatment. You're not going to get B plus treatment. You're going to get D plus treatment because they're overwhelmed.
yeah, yes, they are. And I just, again, like being exposed to the medical community on Twitter, it's a little different than Facebook. I'm actually enjoying their tweets and not enjoying the rest of Twitter because it's a cesspool. But their tweets are really they're exasperated. They're tired. They're burnt out. They are they are really showing signs of fatigue, both emotionally and physically. And the emotional fatigue is also coming from frustration over the fact that, and this ties into the election and post-election, that I again don't want to walk down this path, too too far. So Terry, pull me back if I do go there. 72 million Americans voted for more of the same of what we have suffered for 4 years. 72 million Americans compared to, I think, what was it, 62 million in 2016. So 10 million more Americans looked at the complete devastation of our economy, the small business closure, the overwhelming of hospitals, the death of nearly 250,000, at least recorded deaths of 250,000 people, and infection of 11 million, and said, yeah, we'll have more of that. So what does that say? That says that says that no one's listening to these doctors. No one is listening. Not no one. 72 million people are not listening to these doctors. 72 million people are not listening to these public health recommendations or taking them seriously. They're not understanding the gravity of the situation. They're not. So you and I are living with these 72 million people among us. They are our school board, whatever's administrators.
You want taco?
Do I want a taco? No.
I want a taco. Does he
But-
does he have an in at the CDC?
Yeah, exactly.
Yeah.
Call it CDC and tell him Terry sent you and that you want tacos delivered tonight.
Yeah.
I'm kidding. No, I'm good. I'll come later. Okay.
Okay.
All right. So, so we have to live among. There are school board administrators. There are police officers. There are our whatever that they work in our grocery stores, and if they're not taking it seriously, they're putting the rest of us at very high risk. Okay. And the doctors and the nurses and the whole biomedical community is now 9 months into this, and they're exasperated. The first 3 months, they understood this is a huge impact. We have to be forgiving. We have to let people absorb at their pace and have some time to understand what this is doing. Then 6 months in, we're like, okay, you should get it now. You should understand that people are dying. You should understand that even if they're not dying, they're carrying it, the virus, and spreading it. And so wear a mask and stay away from each other, and don't go to bars, and don't go to rallies. And then we blew past those. And then 9 months in, we're now all collectively, except for Scott Atlas, who's a fucking asshole, we're all like, okay, this is now at a breaking point for all of us. Okay, this is the point at which we lose our professional decorum, and we curse on Zoom meetings, and we let loose on Twitter, and we just say what we really feel as human beings. And so, because this is the last straw, because if you these 72 million people don't take the rest of the 65 days seriously, then they're going to kill another 150,000 people. And then what we're going to do to them is we're going to lock down their communities, we're going to close their schools, we're going to close their businesses. And then please don't point at us, because this will be your doing.
Hey, Sanjay,
Yeah.
they had that viral video from the nurse who was treating
Yes,
these people who were sick.
Yeah.
And these people came in, and though they're sick with COVID, they're refusing to believe they have COVID, since they were led to believe that it doesn't really, it's, a cold.
Yeah.
So, these patients were asking her to check for lung cancer, even though they've already tested positive for COVID, because their disbelief was such a high level because of what they've been fed for months, that the last thing they could possibly have, even as they were dying, was COVID. And
Yeah.
I've been swearing on Zoom all along. So
Yeah.
go ahead. Go ahead.
It's very troubling, because they started with denial, and now they're going to end their lives in denial. And it has served. And one of the things that hurt to listen to was, she said that they're spending their last moments with all of this hate in them. Maybe this woman, this nurse, is a liberal, a Democrat. Maybe there's a deeper sentiment, and maybe there's some of her personal politics in there, but maybe not. Maybe she's just speaking as a human being and a trained RN, and someone who is astounded at the depth at which someone can be convinced of delusion.
Well, and they're actually passing on the opportunity for that last phone call with a loved one.
Yeah.
Because they think that somehow, after taking some vitamin D and some vitamin C, they're going to hop up out of bed, and then in a few days they'll be in a box.
Yeah, and I'm wondering how many of them are in the next few months, or have been since the president was released from Walter Reed, gone into that clinical scenario, or had their family follow them into that clinical scenario and say, where's the Regeneron? Where's the remdesivir? Why aren't you giving them hydroxychloroquine? Okay. And I'm not kidding. I honestly,
you said the H word, Sanjay.
Yeah, I know. Sorry. But you see where I'm coming from here. That now we fought all of this disinformation for all this time. They've now landed in a scenario where their life is being threatened, and instead of saying, being I don't even know what the word is, humble, intellectually malleable, to say, okay, I was wrong, please save my life. Okay. Yeah. That they would double down on the disinformation that they are so convinced of.
Well, they did ask if they could bring the MyPillow in with them, so.
But you said it, you nailed it when you said, I didn't catch that part about the, test me for lung cancer, but imagine that they've become so disbelieving that this is actually a viral syndrome. This is caused by this virus, that they would ask their clinicians to double check or give us, this opinion on whether this is actually caused by cancer. That's crazy. That's crazy. And if there are enough of them, which 72 million voters indicate there are plenty of them, that becomes a massive distraction for the healthcare system. It becomes a massive, massive distraction for them. That then we because still, even in a pandemic, you will have systems practice. It's not just physicians. I'm talking about entire health systems that will protocolize the defensive medicine in these circumstances, so that if they come across one of these patients that demands a second opinion, that they will have protocols in place that go through the motions so that they don't get sued.
Yeah.
Okay.
Eh,
And if
there-
it happens on economies of scale, imagine the waste. Imagine just the massive waste and cost of this to everyone.
Yeah.
So and then that's less for the rest of us. Okay, because it's a pie. All right. Healthcare is a pie, and everybody has to share from that pie because there's only 786,000 doctors practicing currently in this country. There's only 1.8 million certified RNs in various specialties. So that's the pie you have to eat from.
Yeah.
Okay. And so if you are doing things, expressing your politics in a way that risks yourself and others, then you have to avail of that pie. You're taking pie away from other people that will actually need it. And that's so irresponsible and so it's disgusting. There's no other way to put it. You remember, you guys, I've been saying this since May, that I go down to the convenience store. That's my, where I get my gas, in the little convenience store. I don't like to go to the big, whatever. I just go down the street. And for months and months and months and months, I've been saying, I'm proud of my Northeastern PA folk. They've been masked up. They've been, responsible. Last week I go, and there's a woman standing there waiting for her deli order without a mask on. Now, the workers are behind plexiglass and they have masks on. And another guy comes in and he's not wearing a mask. A third guy comes in and he's wearing it, the I call it the dick swinging method, where the nose hangs out. And I just left. I'm not going to stand in their presence. Okay? And I should have corrected them. And actually, I haven't corrected anyone so far. But
do you realize that correcting people have led to fist fights?
yeah, I'm almost in the mood for one, Terry, at this point.
No, if it just ended with a fist fight, I might go for it, but I'm afraid.
Exactly.
I'm Irish German, so it might turn out worse. So I try not to engage.
So yeah, I don't know. I don't know what it is because, and some are saying that. Oh, Katie's here. Well, we should talk to Katie. Katie, are you here? Katie, if you're here, we'd love to talk to you, but I'm just going to finish my point. So I don't think people look at the numbers and the curves like we do. Terry, myself, Mike, and some of our other FB friends, we look at these charts daily. And I go down, down to the county level, and I look at data sets from, not just from Johns Hopkins, but from raw data from CDC and stuff like that. There's all kinds of anomalies. Whoever has run the CDC so far, should be taken out and just put out of their misery, because, and some of these states, like Terry's mentioned, Texas and Florida and Georgia, where they manipulated the numbers, where there are all kinds of strange anomalies over lag of the test results, and it's so self-defeating. It's so self-defeating for these politicians to be doing this. They think they're helping themselves in the public perception that, okay, let's meddle with it. Let's get it, don't report this right now. Let's wait. We'll make an anomalous blip 3 days from now. Nobody will question it, and then we'll just say something was wrong with the numbers. And it's so self-defeating, and they're killing people, and they're destroying their states and their communities and their businesses and their economies. So when they look at this, when there's a lack of focus of these people, then we start to hear the new nonsense. The new nonsense is COVID fatigue. People are tired of hearing about COVID. People are tired of the restrictions. People are tired of being told they can't travel, they can't gather, they can't go to concerts, they can't shop, they can't all this stuff, and they can't have Thanksgiving, and they can't whatever. People are tired, and that's why we're seeing a resurgence in Europe, and we're seeing a resurgence here, and people aren't, they want to go to the bars, and they don't know anyone that's gotten sick, and they're young and healthy, and they're willing to take the risk, and all this bogus shit about why they're unwilling to comply with the basics. Because it's too late, and we saw so many of these. Terry brought them forward a number of times. So did Karen over the summer. Some loudmouth Republican finally got their ass bit by the virus. And then they turned around and said, oh, you know what? I should have taken it more seriously. I feel terrible now that I lost my uncle and my grandmother and my dad and I feel terrible that my wife is now a long COVID sufferer. How long does it take? It takes 6 years to get a PhD. It takes 8 years, after high school to get an MD, then residency. And the vastness of what we have to learn in that period of time. And the book, just everything, experientially, and out of textbooks and out of journals and reference. All we're asking you to fucking do is wear a mask and stay away from people you don't know. That will solve the problem. Dr. Osterholm from University of Minnesota said, if we have to force people because they refuse to and they don't understand the impact of it, he would favor a 6-week complete national lockdown. And last time we met, I said I wouldn't favor that. But last time we met, let's bring up the numbers. Last time we met, look at this. We were around here last time. Okay, guys? We were here. Can you see my mouse going up and down? We were in this region. Come on, make it. There you go. We were right there. That's where we were. Europe was on the rise, and we were following its trail. We were right here. This was 4 weeks ago. Right there. Look at us today. If people are going to continue to behave just completely with complete disregard, then they're producing a threat to themselves and to others. People with mental illness are allowed to be taken in custody and put in medical health facilities when they're a threat to others and themselves. Every state has its own laws to do that. So, sorry, so back here, Sanjay says, no, I don't think we really need another national lockdown. Here today, yeah, I think we might. Because if this goes to where the EU consists of, I think, 26 large nations, 57 if you consider all the whatevers, with a population of 430,000 odd for the entire EU. They reached a stage where they were hitting 220,000 cases a day, and we hit 190. Right? 184, 190.
84, yeah.
But that's not even accurate, is it, Terry? That's confirmed, tested cases. We have said that that is again a proxy for prevalence. That's not an exact count of how many positive cases there are in the United States that day. That's a proxy. And you can multiply that by 3 to approach accuracy of the number of actual sick people with COVID that day, and you can multiply it by 9, okay, 9, to get the, to include all asymptomatic carriers and all of the population that are presenting a risk for transmission. So for every positive confirmed case on that day, multiply it by 9, and you'll get the number of people that are out there presenting risk to other people.
So basically, you have 4 to 5 times more likely to run into someone positive now than you would have 2 months ago.
Correct.
Okay.
Correct. Well, look at this. This is the map that I showed you guys when we met on October 22nd. We were at 6.8 million total cases with almost 200,000 deaths. A month later, ladies and gentlemen, we're at 1.1 million cases. Less than a month later, and we're approaching 250,000 deaths. Some of our pre-show banter should be part of the show because it's very, it's a lot of truth telling in what Terry and I say to each other when nobody's watching. We could see 400,000 deaths by the end of the year, December 31st. Before the ball drops in New York City, we could see this number go to 400,000. That's 6 weeks from today. 400,000 dead Americans. And that case count, 6 weeks, so 6, you're doing 1 million a week, okay? So that would be 18 million. And this goes to, 18 million cases, which would be a proxy for 60 million infected over the course of the 9 months, okay? This is not slowing because of exposure leading to quote unquote the herd immunity fallacy. If indeed 60 million cases have occurred or by either symptomatic or asymptomatic infection in the last 9 months, then we should see at least what is that, 60, so 25%.
65%.
Yeah, 25, so 12.5%. About 12.5% of people should be carrying this quote unquote herd immunity. And then, in actuality, with the exposure of 60 million people, it would be about 25% of people.
So going like we're going,
25 million people would have some, 25% of all Americans would have some protection from COVID, but it's not that, it doesn't work like that.
But with those numbers, only 3 more years of this and we can all have herd immunity.
I didn't think of that, Terry.
Yeah, so there's an upside.
3 more years, you're right, man.
Yeah, get some a work program to go on to dig holes in the ground for the people who don't get it, but
oh shit. That's right. Yeah, it would take 3 more years to achieve full coverage.
Yeah, excellent.
Yeah.
Scott Atlas, good thinking.
You're using straight line projection. It's going to take less time than that.
It would take less time. Correct. It would take less time to achieve it. That's true. But still, I mean, the amount of death and destruction, I think, is what we're, let me see here. All right. So that's that. Yeah. Okay. So, we're seeing a lot of testing lag and the lack of appropriate penetration. So we've been hearing numbers like 120 to 140 million tests have been conducted in the United States. The person who has been saying this doesn't understand testing at all, nor perhaps does anyone on that task force understand the different types of testing. So, this is the frustrating part. Right now, testing is really divided into 4, types of testing, okay? The point of care, rapid testing, point of care is one, rapid testing is another. Medium throughput is what you would see in clinical setting. Okay, medium throughput would be even in long-term care facilities where you don't need to know immediately. You can wait 2 to 3 days. This has actually been the primary way that the United States has addressed this one and then this one. We started out with medium throughput. We tried to move most of our testing in the United States to the high throughput platform, right? But then we saw massive lag. If you remember, some people were waiting 16 days for a result. So, you know, the speed at which you're able to respond to, you know, 1 million tests or 3 million tests goes to 0, right? You can't really, you can definitely, you know, take that many samples in a day, but then to test and respond to those samples takes inordinate amount of time, and therefore it becomes necessary to go through different modalities. So not just the RT-PCR that we started out with, but then to antigen testing and other methodologies until you are, you know, get to point of care, which is those little plastic, you know, kits that we were anticipating would be kind of a spit test or something you could buy at the drugstore. And, you know, was hoping that they would be ubiquitous by now, that you would get them at Walmart, that you get them at CVS. They currently are still nowhere to be found. And I will say this explicitly, it's because the Defense Production Act was not used, and no one was told by the federal government as a result of a national response strategy to create, you know, 1 billion or more of these tests so they could be made available to schools and nursing homes and in airports and other places, so that we could do rapid point of care 5 to 15 minute screening at will whenever we wanted. The great thing about those tests is if you're positive, it tells you you're positive. If you're negative, that doesn't necessarily mean you're negative. Okay, that's over here. All right, but if you're positive, then we can eliminate you from the risk pool by taking you out and saying you go home and don't come out for 14 to 21 days, or until we do a more specific and sensitive test that tells us that you are, one, not carrying it, and then also not sick and no longer able to transmit it. So this was supposed to be in our hands by now, but it's not. If you recall, in September, when we did our September update, rapid antigen testing and these spit kits were front and center in our presentation, talking about making sure that going back to school is as safe as possible, which means that you can test as many kids as you want, whenever you want, test teachers as many as you want, whenever you want, everywhere throughout the country. That was not made available. That is a massive failure. And hey, Rocket, 1 second. Don't you start. So you have your dinner? Okay, so sorry about that. John is not here to dance, and Terry hasn't learned the routine yet. What happened? Anyway, so the this was the this test here, the rapid response analyzer, was the Abbott ID test that had a 30% failure rate, which is why we saw a big outbreak. Oh, well, this is the third outbreak in the White House. So the first outbreak was after Amy Coney Barrett's celebration. About what?
Crushing cans.
Oh, okay, I'll take care of it. Yeah, I got it. I'll take care of it. Don't worry about it. Recycling. Sorry, it's recycling night. Anyway, so that's very important. So this is the rapid analyzer, the Abbott ID and other, the Cepheid, Gene Express. So these were the ones that kind of had a failure rate that was considered acceptable because at least they got you a result very quickly, right? Within an hour or less than an hour. And then these were the platforms that the other big labs like LabCorp and Quest and all the other ones were using, where they stick the swab up your nose and then they're supposed to be able to tell you within 2 to 3 days. But then they got so backed up throughout the country that some people were getting their test results, 8 to 16 days later, which was useless. And we talked about why it's useless. So if we don't address this in the next 6 weeks, which I'm very sure that we won't, then we will have to address it immediately after the inauguration in January. Because this needs to be ubiquitous. As soon as you figure out that somebody might be positive, you move them through this process of getting them specifically and sensitively tested, and then you make them quarantine.
So Sanjay?
Yeah.
So even we get to the inauguration, January 20th of 21, right?
Mm-hmm.
To get any organized response out is going to get you into the beginning of March.
Yep.
To get additional lab facilities online to pick up the excess may be longer.
Yes.
So it's not going. There's not going to be a big change until 2021, no matter what.
Well, 22. Oh yeah, you're right. So
that's just me raining on the parade. Don't mind me.
I mean, like, it's not going to be me, but people better than me, like like Vivek Murthy as the head of the coronavirus task force. I don't think you could pick a better person. He was Surgeon General under Obama. He's extremely highly trained. He went through everything with both H1N1 and Ebola and Zika. So like he knows what he's doing when it comes to this stuff. And the first thing I believe he's going to recommend is the Defense Production Act. It's not going to be Ford and GM. It's going to be, companies that actually do this are going to be given the money, the supplies, and the personnel to produce these tests and send them out to every school, every nursing home, every doctor's office. They're going to be pallets of this stuff shipped throughout the country, because there's no other way to get a grip on the pandemic unless you know who has it. Okay, so we were very premature, myself and others who were talking about the antibody test. I sent Terry to get
Thanks. Yeah, that was a big help. Thanks.
He spent $100+ $150.
Yeah, I could have bought candy corn with that. So.
I know, but it's because we didn't know what we were dealing with. Okay, and we didn't even know what we needed to know to make the response effective. So right now, not knowing who has it and not being able to test everyone all the time until we can suppress this down to less than 100 cases per state per day. Okay, less than 5,000 cases nationally per day. Until you can get it suppressed down to that, okay, that's one approach. And Mike Kidd, our friend, talked about why it's much easier to do that. Okay, it's actually easier. It takes less resources to keep the transmission rate that low once you've achieved it, than it is to try to continually crush down 40 to 50,000 cases a day down to 20, or 20,000 cases a day down to, to something more manageable. The track and trace infrastructure, the testing infrastructure, the amount of stuff that you need to deal with case levels this high, it becomes exponentially more difficult as these numbers rise. It becomes derivatively less difficult when you when you've got it down to 100 to 500 cases a day, okay, per state or whatever, so that the case count is just at minimum. Then when you have a zip code level outbreak, you can amass the resources, you can lock down the businesses or whatever for 14 days or even 8 days, and then, so there's less economic impact, okay, because then once you know who has it and it's no longer transmitting, you can lift the 8-day thing on the businesses there, and they can go back to businesses, they can go back to their normal routine, because the people who were potentially transmitting it are no longer in the community causing risk. They're aware of their illness and they're being treated, or they're being watched so that they are don't fall into further trouble, right? So testing is, we started about talking about testing in March. So we were still not there, and it may be, as Terry just mentioned, March of 2020 before we achieve what we should have achieved very early in this pandemic.
2021.
Yeah.
March of 2021.
One full year before we achieve what we were supposed to achieve early in this pandemic. So, all right, I'm going to pause here and see if there are any questions, and then we can talk about the vaccine. Laureen had asked me on Messenger, and I haven't been on Facebook or using the Messenger actively because of my ban.
Hey, I did just delete a question off the MD page where someone asked if Corona was running around in Italy in 2019. And if you're asking that in November of 2020, I just fucking deleted it because it didn't rate a response. What the hell? Maybe it was at Normandy in 1944. Fuck that.
Yeah. So, yeah, I mean, I think our tolerance, our patience has worn out, dude. I can't. I mean, we've done that. We've answered questions. We brought forward novel science. We've elucidated everything, everything that's come forward, from testing to treatment to vaccines. And at this point, if you're not willing to educate yourself, I don't know. I don't even know if it's dangerous to let that person back in the public without an answer. But I don't know.
That community group, someone was saying some ridiculous bullshit, and I think Laureen saw it. I said, keep the wackadoodle stuff on your personal page.
Yeah.
I ain't got time for it no more.
Yeah.
Keep the wackadoodle conspiracy, blah, blah, blah crap on your personal page, and don't bring it into the group that I'm monitoring, I just delete them.
Bernie, you're being incredibly rude. This is Bernie Sanders Udoshi. He's named after my second favorite guy from Vermont. My first favorite is on the Zoom with us. All right, bud. All right, I love you too. Go, get out of here. All right, so now, any other questions about testing? Has anyone been recently tested? Has any experience with a turnaround time? Any questions? Yeah, is Katie with us?
Oh, she dropped off.
Okay. Anyway, so
no one's been tested or nothing.
I know Gerda's been tested. Gerda tests regularly, but has there been anyone with experience with testing recently? Okay, and Leslie, are you going to be tested? And I know you have an upcoming procedure. Do they have you testing a specified time before your procedure, or?
I got tested last Monday before the 2 procedures I just had last week. And they said, no news is good news. If we don't call you, that means you're negative. So that was fine. And that was 2 days in advance of that.
Okay.
And then I'm supposed to get it 2 days before my heart surgery in December as well. Right.
Okay. So it's 2 days. Good. Okay. Yeah. And so no question on that. All right, let's go. Let me try this. Am I sharing my screen or no? I'm not. I don't think I am. Okay, share this.
We did get a late question, Sanjay.
Okay, go ahead.
Oh, there we go, from Don.
Yeah.
Who doesn't have his beret on, so he can't ask himself. What's the potential for the complete fall apart of the medical treatment system if PPE is not available? If essential personnel start dying or being incapacitated by COVID, how soon does it become impossible to meet the need for treatment?
That's a very good question. And actually, there was a model that I looked at, and it's not, it's not verified. It's just conjecture at this point. That at 500,000 cases a day, we would then exhaust capacity, and because if you, for example, it's such a geographically disparate phenomenon, or it has been. We had a northeastern impact and a northwestern impact as our initial, foray into the battle with COVID. Right, we had Seattle and Portland in the northwest. Then we had New York as the epicenter in the northeast. But you have to understand also Philly and Boston were also Boston especially were heavily affected. So geographically, each of those areas being urban, were able to surge resources, and they're being academic medical centers, with multiple hospitals and multiple major health systems. Even at the peak back in the very first wave, even though they anticipated they might be overwhelmed, they never got close to being overwhelmed. Okay. In Wisconsin right now, and in Utah and in some other places, locations have been overwhelmed. They are absolutely at 105, 109% ICU capacity, which means that they filled all their ICU beds and they've added flex ICU. So they converted some other part of the hospital to the same kind of facility around that bed that you would get in the ICU. At 500,000 cases nationally, with the spread being uneven to community hospitals and not urban centers, you would see a breakdown locally. You would see the hospitals picking up the phone and asking National Guard medic units and other large health systems to contribute their doctors, nurses, and resources. But above that, nobody has really modeled what would happen to the U.S. healthcare system. What is the breaking point of the healthcare system is unknown. It's truly unknown. What is our strategic national reserve levels for PPE? At what point do we completely run out of certified clinical grade PPE so that we start using trash bags and, non-clinical, non-medical grade equipment to handle patients? That could happen at any community hospital. That could happen next week or 2 weeks from now at a community hospital. It's much less likely to happen in a major medical center or in an urban center, but it could happen.
And a follow-up, increase at whatever exponential applies. Straight line doesn't work, will result in that 500,000 by when. And I just want to say that I read an article on an estimate in the first 4 months of the pandemic that they said 5 to 12% medical retired early.
Yes.
Jumped out of the way, and we have actual small clinics geared towards other things now are closing down in these hot areas because there is no business to be done for them.
Yeah.
So specialties, the surgeon who works on joints, is not getting the room to do his job. So he's packing up his shingle and retiring early. That's just where we're standing.
Yeah. So I think that, yeah, I've seen articles about doctors in their late 50s that have had, successful practice for about 25, 30 years that are they're non front line, I should say. They are specialists, nephrology, pulmonology, chronic care of patients like, with chronic conditions, endocrinologists, cardiologists. So these are in normal time physicians that do, chronic care of large populations. Sometimes these practices have 3,000 or 4,000 patients per physician. They're either independent or they're part of a larger health system. They closed shop.
Yeah.
Okay. They closed shop because it was impossible to operate under these conditions. And then it's not like they can retool and then go work as hospitalists, at age 58 after doing this for the last 30 years. It's not, a lot of them tried. I mean, a lot of them in surge circumstances ran ambulance. JJ, our friend in Minneapolis, in Minnesota, is an MD PhD trained psychiatrist. He's been running ambulance for his county hospital. Okay. He's been off for the last 3 days, but there hasn't been a single day he hasn't worked. So for his day job, he's had vacation time that he's been forced to take because of whatever issues with their HR. But because they're so short-staffed, this young man, mid 40s, physician, highly trained, doesn't do this for his day job, is running ambulance with medics who are exhausted. Okay. You can't get enough people on shift anymore in some of these locations. So Don's question is, at which point is a breaking point? It changes for each location, but you're seeing a lot of communities approach that breaking point. So nationally, we don't know what the breaking point is. That's my point. But locally, it may be much more fragile than you think. Okay, so there's that. All right, so let's talk about the vaccine. There isn't much more to. Oh, sorry, hold on. There isn't much more to say about the vaccine than what we've already presented in previous town halls. So, for example, we talked about this before. Look, there are 5 major strategies or platforms. Okay, so the platform that you're seeing here down here, and Maureen's question to me over the messenger is something that I'll address right now. She asked me about my statement earlier, I think in the summer, where I said, when I described this slide, the first to market platform is going to be this one because it's the easiest one to bring to market. Okay, so let me take a moment to explain why I said that and what that means. mRNA is a macromolecule. It is one of 4 types of macromolecules that we've classified, as organic necessities for life. So you have carbohydrates, you have proteins, you have lipids, and you have nucleic acid, right? So nucleic acid is the blueprint for all of life. All of the proteins in your body have a set of genes that code for the equivalent in amino acids. So for every 3 nucleic acids, there will be 1 amino acid sequence in the sequence of a polypeptide. So why am I explaining it this detail? It's because what was able to be done by Pfizer and Moderna is that early on, when the Chinese described the virus and then were able to sequence it and transmit the sequence to the global medical community, the sequence they provided was the nucleic acid sequence known as mRNA. Okay, so this is a single strand of the nucleic acid. The double-stranded version is called DNA, deoxyribonucleic acid versus ribonucleic acid. So the DNA is 2 strands. You can see it here. They wind around each other in a double helix. This is the simpler version, which is just a single line of nucleic acids. The Chinese transmitted that to the global medical community. The global medical community did what we call sequence analysis, where we could see every 3 of these mRNA sequence. In every 3 is a codon that says, okay, this is the protein that it's going to create. When you isolate a specific region or gene, you can then say this is the region that codes for the spike protein. Okay, so when this enters the machinery of the human cell, this part will then be read by the machinery of the human cell and translated into a protein, and that protein will morphologically form the spike. Another sequence gene will form the envelope protein. Another sequence will form the RNA-dependent polymerase. So down the line to about 41 genes or 41 polypeptides in the sequence for the RNA are produced in different parts, like the parts of a Ford Mustang or whatever. And then they come together to are assembled inside the human cell. And then that becomes the new virus, all right? So one virus enters the cell by injecting its genetic material. The genetic material goes inside the cell. And then, and now I'm talking about with SARS-CoV-2, it starts up here in the upper respiratory tract. It infects the endothelium of your mucous membranes, and then it descends into your lungs. It replicates there and causes systemic disease. So the replication process down at the molecular level is the mRNA enters, and then it creates all these various parts: spike, envelope, polymerase, et cetera, and they assemble in a kind of assembly line that's hijacked by the virus inside your body. And then it produces so many of these viral particles that it kills the cell. And then when the cell dies, all those virus particles spill out and they go on to infect all the cells next door. Okay? So that's why it takes about 4 days before the inoculum that hits your nasal passages or your, whatever, or your upper respiratory tract, to get to a point where it starts to make you feel sick. You get enough death and destruction in your upper respiratory tract. There's enough virus for it to then go down into your lower respiratory tract. It takes about 2 to 4 days for all of this replication to happen before you start feeling sick. Sometimes you'll get replication and it won't descend. And whatever innate immunity you have up here, okay, will stop it from descending, and you'll be asymptomatic. 40% of people will carry the virus up here. It will never descend to their lungs. They'll develop some sort of innate effectiveness of their antibodies and the mucous membranes. It'll kick out the virus. During those days of being asymptomatic and carrying it, the low-level replication isn't causing illness, but it's shedding. Every time you speak to someone, it's shedding. Remember the demonstration that Terry gave us with his vape pen? It's invisible, but it's shedding all the time. And the only thing that keeps it from shedding more, effectively is the mask usage. The only thing that keeps it from coming from a person that has shed it into your nose and mouth is mask usage. All right, so we're now down to the mRNA. All right. So we've isolated the mRNA that codes for the spike protein because the spike protein is antigenic. It is the part of the virus that causes our immune system to say, hey, that's a virus. Let's produce a response. B cells get involved, T cells get involved, cytokines, all this stuff gets involved, and an immune response builds to that spike protein so that antibodies will come in contact, antibodies will be produced by us in our body. They'll come in contact with any spike protein that looks like that, okay? And you get effective neutralizing antibodies that then clear the virus by calling in various other elements of the immune system. All right, now, all that having been explained, why did Pfizer and Moderna choose to use this as a way to inoculate, to vaccinate? Super simple. And I'll make it clear why it's super simple compared to going this route or this route or this route, okay? These are traditional platforms, and these traditional platforms have been used in other disease vaccination like measles, mumps, rubella, polio, influenza, et cetera, down the line. All your childhood vaccinations, tetanus, pertussis, okay, diphtheria. And they've been successful in creating neutralizing antibodies that carry with you either for a very long duration or for your entire life. Sometimes they need a booster dose, but we've had these for 30, 40, 50 years. We know they work, live attenuated, or, we take another virus and make it look like the virus we're trying to vaccinate, or we take the protein and that we know causes an immune response, and we purify only that and give it to you, and then your body produces a response. We went all the way down to the simplest way to do an inoculation. That is, take the mRNA, purify it, stabilize it, put it in a solution, put it in a vial. At this stage, the thing to remember is that nucleic acid compared to carbohydrate, compared to protein, and compared to lipid is very, very, very fragile. In the human body, it is so fragile that the half-life of mRNA is measured in minutes. Okay? But the way we protect our DNA and mRNA is that our body wraps it in proteins. So when you see a chromosome, it's tightly wound DNA that's wound around proteins called histones, and that protects the DNA from degradation. And the different chemical aspects of histones and methylation allow that DNA to expand and contract as and when needed, so that when a gene is active during like growth phase, like when you're a kid, like my children, they're growing, their skin turnover is their soft skin because they're constantly replicating and growing. Okay, when they hit adulthood, some of those genes shut down. They stop growing in height. They stop, whatever. They the rate at which they turn over cells slows down. So that shuts down that set of genes. All right. So that's how that we protect it in a normal functioning cell. But in a vial that consists of highly purified mRNA that specifies a very specific viral protein, you need to add chemical preservative to stabilize it so it doesn't fall apart in solution. And then you got to freeze it, because heat is the enemy of all molecules. Heat causes molecules to bump up against each other, hydrogen bonds to break, and then they fall apart. When there's no heat, when it's frozen, it stays good. Okay, so that's why Moderna says it's stable up to minus 7 degrees Celsius, and Pfizer says it's stable. Their solution is only stable at minus 60, 70 degrees Celsius. So the two viral vials, the vaccination vials, one from Pfizer, one from Moderna, have two different standards by which they need to be frozen for distribution. And that changes a lot of things in logistics. And Terry and I will actually try to recapitulate our conversation from before we started, but it's a logistical nightmare. Okay, so Lorene, if you're still with us, that is the difference between that's the approach. Okay, that's the platform that is now first available and first to market, and that I tried to produce. I tried to explain the reasons why it's so easily produced in such a short period of time, because it is the simplest molecularly to do. Okay, now her question further went to, would you take this, even though you said earlier in the summer that this is the platform that's novel, it's never been used at this scale, and therefore It's not necessarily a trusted and well-known platform that has worked in the past across, decades and millions of people. That's a hard question to answer. If what we're seeing indicates a breakthrough in vaccine development, a next generation vaccine platform that allows us to do vaccinations rapidly and effectively, then I'm all for it. If you're asking me if there's evidence for that claim right now, that this is a next generation vaccination platform that is highly effective and, will generate rapid results, I can't give you that evidence because that evidence doesn't exist. Only 30,000 patients for both the Pfizer and Moderna vaccines have evidence of effectiveness currently. 30,000 was the number of patients that were tested using these vaccines. Okay. So in that group of patients, it was effective in producing an antibody response. Okay. In those patients tested 90% of the time in Pfizer and 94.5% of the time in the Moderna vaccine. All right. Is that the yardstick by which I and others in the healthcare community can say, this is it, this is safe, it's effective, it's the magic bullet? No. Millions of people need to be vaccinated before we get real world results. Okay, and real world results will not be 90% effectiveness. They will not be 94.5% effectiveness. Okay. Real world effectiveness means patients of various ages, various comorbidities, various, states of even musculature matters. So in elderly populations, there are less satellite cells in the musculature. Satellite cells of the skeletal muscle are adult stem cells, naturally occurring adult stem cells. They are abundant in young in people of a younger age group because, as Terry and I can attest, when you lift weights at age 22, it shows up, 2 days later. When you lift weights in your 40s, you'll have to do it 6 times to get the same results, right? You just have less ability to grow muscle because you have less adult stem cells the older you get. So above age 65, the effectiveness of the mRNA platform is likely to be very different than for those in their 20s, 30s, 40s, and 50s. In the children, again, it may be a very, very effective vaccine because they still can, there's a lot of adolescent and juvenile stem cells, and uptake of mRNA and production of the antibodies and the response is very robust in young people. But take 30,000 kids and compare them to 30,000 65 plus year olds, and the average of effectiveness is going to be very, very different.
Hey, Sanjay?
Yeah.
Both companies make a claim on the percentages, but they don't have to provide the paperwork to back up that study until they actually go to the FDA.
Correct.
For the special use involved in distributing the vaccine itself. Because I'm the cynic, both of these were announced and there was a huge push on the stocks of these companies. And I would not be shocked to see that when it comes time to put that paper on the table, we're going to see something much different than what's been announced.
Absolutely correct. Absolutely correct. And so this is a good time for me to go over what Terry and I talked about, which is, when you get any medicine from the pharmacy, any prescription medicine, there's a tightly folded piece of paper, glued or whatever, taped to the bottle. It's either the patient-facing white paper, or in the doctor's office is the one they give us in hospitals, doctor's offices, is the provider or physician-facing white paper. The physician-facing white paper details all of the contraindications, all of the adverse effects, everything that was encountered of any significance, and the percentage probability of it occurring in different populations, age groups, et cetera, et cetera. It's a highly detailed piece of kit, that they give us, prescribing information. And nothing in that, and it's first written from a scientific and biomedical perspective, then it's reviewed by lawyers, okay, for all kinds of liability concern, right? So you will never see a claim like 90% effective on a physician-facing white paper. I doubt you'd ever see it on a patient-facing white paper either. They are warning labels, basically. But they're extremely detailed warning labels, much more than can fit on the 3 or 4 lines underneath, whatever on the pill bottle. And that's what we're really awaiting from these companies. So beyond the phase 3 clinical trial, which is cleared, the phase 4, which is, may or may not involve challenge, and I'll explain what a challenge trial is. If the percentage effectiveness will change not only dramatically on the populations that were used and treated, but it will change dramatically as the N of patients gets to be in the millions. So for 30,000, the effectiveness may be 90%, but across all populations, across geographies, across comorbidities, across multivariate, analysis, that effectiveness is probably going to come down significantly. How significantly? Well, current flu vaccine is considered to be 54 to 67% effective. Okay, that's across massive populations, across 40 years of data, right? The FDA had set a threshold of, I think, 50% effectiveness for any vaccine that's developed for COVID. And so to hear that these two companies achieved 90 was like, oh, wow, they blew away the threat. They just blew the doors off this thing. But let's go back to what Terry said. And it isn't even just being cynical. It's just being, I guess, observant is the best way to put it, which is these are PR releases. This is meant to create hype. This is meant to give the public hope, okay? 2 things can happen with that hope. One, it can be completely misconstrued, and that we now have a magic bullet, and therefore I don't need to wear a mask. I don't need to pay attention to public health recommendations. I can have a huge Thanksgiving. If anyone gets sick, we have Regeneron, we have remdesivir, we have dexamethasone, we have these 2 vaccines, so that we can, quickly vaccinate everybody. It's going to be here by the end of December. None of that should be considered valid at all. It should not be considered a valid assessment or interpretation of these announcements. The other way to look at it is, it's going to take time, effort, energy, patience, but this pandemic can end sooner rather than later if we all mask up, if we follow the public health recommendations, if we stay out of public, if we don't congregate, if, all of the things, because in a few short months, and we've survived 9 months now, in the next 4 to 6 months, let's call it, this could be a generally available solution to ending the pandemic, that we can mass vaccinate. The responsible among us will be the first to consider all of the risks of vaccination and then get vaccinated. Okay. Are we looking at an ideal candidate with Pfizer and Mrna? No. Will we ever have an ideal candidate? No. No. Okay. And then, the question that Terry and I had and we promoted it. Let's go back to that slide. Is that, you know, we would rather see a traditional approach with, you know, all of the caveats that have led to effective vaccine development in the past, and all of the steps and all of the, you know, scientific, academic, and the rigor that go into production of vaccine, all of those steps adhered to around any of the proven platforms. Okay, we'd love to see AstraZeneca come out as they have promised, in collaboration with Oxford and the National Health Service in the UK, in the next weeks to months, come out with an announcement that they are now done with their phase 3, that they feel that their viral vector-based vaccine, which is right here, okay, which is the chimpanzee adenovirus, which they modified to look morphologically like the SARS-CoV-2 virus, and you know, it is not disease-causing or infective. It is instead just a decoy on which the immune system will train itself to fight SARS-CoV-2. That they've done it, that they've gotten 70-80% effectiveness. They've gotten a safety profile that is very similar to the flu vaccine or any of the previous vaccines on which this platform has been utilized. That they can produce it and distribute it without having to need freezers and liquid nitrogen and dry ice. And that they can mass produce it in collaboration with all of the World Health Organization collaborators throughout the EU and Asia, and that we could do 2 billion doses in the next 6 months. We'd love to hear that. And that will happen. But even that is not magic bullet. It's not the trusted platform, because unless you vaccinate 1 million, 10 million, 100 million, and look at actual real world results, there's nothing that can truly predict effectiveness and safety.
Sanjay,
Yes,
can I ask a question?
of course. Always.
Is it going to be something like the flu shot, in that right now, I just got my flu shot a couple days ago or weeks ago, and they gave me one for people over 65 that is 4 times the amount of antigens in it than the regular flu shot, because of our depressed immune response. But so I mean, is it a possibility that they'll do that for the elderly or people with comorbidities? They'll give them more.
Yes.
And I've always been told that you should get a flu shot, because if you get the flu anyway, it's probably going to be a lesser disease sequence of it. It won't be as bad as if you didn't have the flu shot at all.
That's true also. Absolutely.
Okay, so that will apply to this, right?
Yes, it will. Correct.
Okay.
Excellent.
And then,
go ahead.
And then one other thing, I watched on MSNBC this morning, Dr. Peter Hotez was on there, and they were talking to him, and they asked him straight out, would you get this vaccine? And he said, absolutely, he would do it. And he'd give it to his family. And he said the only problem with it is the thing about it having to be refrigerated, and then also the 2 doses. And I could see the 2 doses could be a big problem for a lot of people. Some people are going to just get 1 dose and they're not going to show up at 3 weeks afterwards.
That's a real problem, because the booster is the one that makes the T cells kick in. Okay. I'm sorry, the B cells kick in. So the T cells will be involved in the initial response. The second dose is the one that really gets the immune system to have that immune memory. Okay, so the T cells will take care of antigen presenting cells, will take up the initial dose. They'll do all, it'll do all the stuff that normally happens when something novel is detected in the bloodstream and the immune system, does its initial surge, okay, of response. That second dose, because of the nature of it being mRNA, is where the body says, wait, I know what this is. We just saw it 3 weeks ago, 4 weeks ago. Let's get the B cells involved, okay? So then it goes out and picks them up, shows them to the B cells. The B cells then are the immune memory, okay? Now, you'll ask, well, why is that different? Why do some vaccines only take one, okay? Because of the way that mRNA degrades so quickly over time. All right, you need that second approach. You need that second showing of the antigenic picture to the immune system when it comes to something so highly simplified. You can have this hanging out. Live attenuated vaccine and viral vector based vaccine isn't going to degrade in minutes to hours or days. It can hang out, and it can be that decoy in the bloodstream, so that if it wasn't detected in the first few hours or days, maybe 3 days or 4 days later, somewhere along the way, it will come in contact with the right immune cells for it to stimulate a response. All right. So there's so much nuance, molecular nuance here, that I could spend days going through each of these platforms and how we actually step by step create them. Okay, what's the actual biotechnology behind it, and what are the positives and negatives? Now, what you brought up about Dr. Hotez saying that would he take this vaccine, that's great. I think I heard Dr. Fauci and
He said it too.
Gottlieb and so many others that I respect say, yes, I would take this vaccine. And it's because look at it. look at what we're doing. It's so simple. It's so straightforward. It's single ingredient. Okay? There is no molecular complexity here. There is no massive macromolecule, okay, for the body to have some strange response in the liver, and the kidney treats it differently, and it interacts with some protein in the blood-brain barrier. No, it's just this tiny piece of mRNA that gets taken up by the satellite cells in minutes to hours after injection. And then that takes a couple of days for it to do the reproduction. And that takes a few weeks for the immune response to stimulate. And then we give it again so that the B cell response kicks in. It's so simple and elegant, okay, that the risk of it being dangerous to anyone is very, very low. Let's be very clear about that. The only thing that I'll reiterate is that it's novel, it's next generation, it is not proven, all right? So we may go through all of this and vaccinate a bunch of people. And the thing I forgot to mention is, because of its simplicity and because of the fact that it's single antigenic, it's not polyvalent, not polyantigenic, the body might forget about it in 3 to 6 months.
Yeah.
And Sanjay?
The body might say, well, this isn't really a risk.
Here's the thing, though, and this is the big if for me, all right, is both of them have very strict transportation requirements involved on the freezing of them, okay? And I've been in transportation, and that so much can go wrong, and you'll be getting a shot of something you think is a vaccine, and what it is sterilized water by the time it's heated up in transit.
Yeah.
You know what I mean? So, and you're never going to know. Yeah. You're relying on every step up until the point it goes into your arm that it's been treated perfectly.
Yes.
And if it has not been treated perfectly, it is a waste of your time.
Yeah.
It is giving you no protection whatsoever.
Yeah, that's a great point. And, you and I talked about it before we began this thing, and it's so difficult it's easier for Terry to talk about this because he has experience in logistics than for me to explain. But let me talk about it from a last mile or endpoint perspective. Let's say I'm running a clinic or a small hospital, community hospital, or whatever. I get it, and it's so rare and so necessary that even if it lands in my hands, and I hear that the truck's refrigeration broke down, so for about 2 hours. By the time the next truck came along, somebody checked it and said, no, it didn't thaw. We put it on the next truck. It's fine. Here's 25,000 doses. And we kept it at around 10 degrees. It never went above 10 degrees, Doc. Don't worry about it. Okay. Should I trust it? Should 25,000 people get it? Am I making that decision? Or is the logistics guy making that decision? Like, there's just a lot there. There's a lot to unpack. Ideally, it gets packed in liquid nitrogen canisters. It goes to an academic medical center. It's stored at -80 degrees, and every single vial is thawed for the exact 37 minutes, and then before injection, all of that stuff. But it's going to be tricky. It's going to be a logistics nightmare. And there's going to be a chain of custody too for every vial, right, Terry? Like
Yeah.
You got to know, manufactured on this date, frozen on this date, placed in this, in custody in this freezer at this date, transported at this temp, like the whole thing, the data chain, along with, what we used to call the metadata associated with the transport of it,
But the paper trail on this stuff is going to be equivalent to the Encyclopedia Britannica.
Exactly. The paper trail, that's the word.
And the only one who will know if that failed is Leroy, the truck driver, who stopped in to get, a sandwich at the diner.
Forgot to leave the engine running.
Yeah, water is pouring out the back of the truck. You know what I mean? And he's got to make this delivery, and he ain't going to say shit.
Yeah.
Just saying.
It's horrible to laugh at it. But
and the thing is, I ran a freight broker out of Chicago, and I could tell you horror stories of how they've tried to squeeze around the corners. So.
Yeah. And so, last week he had that press conference to take credit for what Pfizer did. And he trots out another general, another lackey with medals on his chest, and he says, "This is the guy that's going to be responsible for vaccine distribution." I went, "Oh, fuck," because Terry just nailed it. I don't want an army guy in charge of this. An army guy is great for getting equipment and men and tanks and stuff that is hard to kill to somewhere where they have to go kill people. But this is the opposite of that.
You mentioned that, and I recall seeing a video of them parachuting supplies and vehicles out of a plane into this field, and every third one of them slammed into the ground at 200 miles an hour. And he picks this guy. Okay.
Yeah.
Turned out great. Thank you.
It would be tough.
Sanjay?
Yes.
Dr. Hotez said one other thing. He said that I guess he's at the University of Texas.
Yeah.
And that his company there, BioE, is working on a recombinant DNA protein vaccine.
Yes, great.
And he said it's going to require no refrigeration.
Yeah, much tougher.
And it's going to be super cheap.
Yep.
So he was putting a shout out for his product too.
Yeah. And okay, so let's cover this too then. Earlier this year, we covered some vaccine stuff. We posted a lot of stuff to our resource page, and we had a debate between some of our PhD friends and an MD PhD friend of ours who's an immunology expert out of India, Dr. Sunil Nuthi. And so I asked him a couple of months ago, is there cross reactivity? Is it a problem? Is it problematic? If you get one vaccine platform now, and then you learn 6 months down the line that it's not effective, it's not a long-term effective platform, or that this new or some other platform comes into the market with greater, efficacy and other benefits to it, can you then switch platforms? And that was a concern of mine for lots of, different reasons at the molecular level. And he said, actually think about it. And then he talked me through all of the different steps of the immune response. And he said, you should not worry. If you decide to switch platforms, you can definitely do that. My initial concern was the entire, you need to have a waning of the entire initial immune response from the first platform before you could get a different one. And that might take 18 months or 2 years, and he said, no, that's not a concern at all. That in fact, you don't even have to wait for those initial antibodies to no longer be detectable. There's no tests that you need to clear to go and get a second vaccine. The only thing he did recommend is you give yourself 3 to 6 months between the two platforms, a minimum of 3 months. And then, if we learn that this initial mRNA platform has limited efficacy past 6 months, and we get that data out in June, okay, and we all went and got vaccinated in April or May when it's generally available, and then at the end of June, July, or August, data comes out, whoever, Stanford or Mayo did a study, and 220,000 patients didn't have detectable antibodies, 90 days after vaccinate second dose. And we don't know if this is indicative of anything of the mRNA platform. Then we decide to switch. We can then go in the same year and get the Dr. Hotez's, or one that doesn't require all of this refrigeration, or the one from the UK, the AstraZeneca Oxford one. Okay, so just wanted to make sure you guys know that. We wanted to talk about long COVID. I don't have much to say other than I very much hope that on January 22nd or 21st, I should say, that the coronavirus task force sets aside a few $1 billion for long COVID clinics, because we are seeing huge numbers of people with various long COVID symptomatology. And we talked about long COVID many months ago, where, okay, see if I can bring, okay, so we talked about long COVID's major organ damage, starting with the endothelium. So the endothelium of the lung vasculature is this inner lining of all the blood vessels in the lung, okay? It's all of these cells that are responsible for letting things in and out of the bloodstream in the lung. Damage triggered there causes a cytokine storm, a response that is a derangement of the immune system that tends to shut down the lungs as effective ability. It affects its ability to get rid of carbon dioxide and take in oxygen. That derangement then spreads. So it goes to injure the not just the tiny blood vessels of the heart, but the musculature of the heart. It goes on to damage not only the little blood vessels around the nephrons in the kidney, which are responsible for filtering out the blood, but it actually, it can actually shut down a kidney, cause acute kidney injury. It can then go on either through the lung route or actually via the gut route. When we see a lot of long COVID patients who complain of diarrhea and GI symptoms early in their illness. and that actually then the damage caused in the gut vasculature travels to affect the liver. Okay, so liver injury. So we've seen patients have to get bilateral lung transplant. We've had patients have their acute kidney injury and have to go on dialysis while in the ICU. We've seen massive injury to liver and the heart. Have when you do the cardiac enzymes, it looks like they've had a heart attack, but they didn't. It's just a massive ischemic injury to the heart. So it's terrifying what this virus can do if it proceeds through its worst course of damage and disease causing across the continuum of organs. Long COVID can be a result of a prolonged recovery period from all of these devastations, and one or many, as I just described, or it can be a very insidious course of a constellation of symptoms that are sequelae to being sick. So women especially have been the worst affected. I can go into the genetics and stuff like that, but it doesn't seem like there's a point or an audience for the genetics. All I can say is that women are affected more. There is an autoimmune component. So those with lupus and those with rheumatic arthritis have a gene associated with those that even if they are not sufferers, even if they are carriers, it causes a predilection to long COVID. So, and it's not clear which specific autoimmune diseases are gene carriers for these autoimmune diseases are the ones that are going to definitely have long COVID. And so if we were able to assess those who had a very high chance of having sequelae from long COVID, you would protect them more, right? We'd be able to do a clinical genomics or gene sequence and say, listen, this runs in your family, or you have this specific gene. And if you get COVID, it looks like you could be in recovery for a long time, or you could be debilitated. And therefore your risk factors are such that you should just not work. You should not, attend school. You should, for whatever period until vaccination is available to you, you are at the highest risk. I wish we could do that, but we can't right now.
Sanjay?
Yeah.
It goes along with something I was reading. Asymptomatic and even very mild sufferers of COVID are still prone to long-term illness. And no, it's not on the same scale as, if you'd gone through a cytokine storm and you have all this visual, physical representation of the disease. But I follow a girl on Twitter who had a stroke out of the blue after her positive testing of COVID, and her life has just been miserable since then.
Yeah.
And this has been ongoing for her for the last, I think, 9 weeks. And she has to watch all her medicine. They've given her medicine where a side effect could be a stroke.
Right.
Because they're going on a basic premise of how to treat a person in her position. Unfortunately, she's going to be more prone to this now for maybe the rest of her life.
Yeah. That's an excellent point. I want to reiterate that. You don't have to have suffered the worst course of disease to end up with long COVID. In fact, a large percentage of long COVID sufferers have gone through the mild or moderate course of disease. Okay. So, JJ asked me the other day about the percentages, the breakdown and you know how it compares to you know, whether an asymptomatic patient, asymptomatic positive, could potentially have long-term consequences, and what percentage of those with mild or moderate disease do have sequelae. And these are very nuanced questions, but we're seeing that the breakdown is that there is neurological damage in these mild and moderate condition, mild and moderate sufferers with long COVID. So the neurological damage could be COVID fog, continuing COVID fog, which is a state of confusion, almost, what would you call it? There's a difficulty in remembering your basic words, concepts, memories, short term are lost. Difficulty in focusing, so someone can be speaking to you and you're not able to actually make out what they're saying. It's just a noise, and that comes and goes. You know, what part of the brain is damaged as a result of having sequelae from COVID? We're still trying to figure that out. I mean, to the extent that there are studies being done with the MRI and CT and of the head, and to see which aspects of the neural centers of the brain are actually affected by COVID, and long COVID specifically. And then fatigue, just a fatigue, and then associated with that fatigue is depression, an inability to motivate or self-motivate, ability, you know, this, and then anxiety, this the feeling of impending doom. These patients are, they are actually being told that there's nothing wrong with them, because you can run blood test after blood test, but the symptomatology is not showing up on any lab or any imaging or anything, but they're not normal. They don't feel well. They are not back to pre-infectious baseline, pre-infection baseline. So you know, we've talked to a number of young women here on the in the town hall earlier. One of the earliest infected and recovered persons that I can remember is Elizabeth from up here in northeastern Pennsylvania in Scranton. I was able to speak to her personally, and she told me the story of her travel in January to New York and Nashville and back home, and about a 3-week period of illness in early February, before any of this had been announced as having arrived in the United States. So clearly she contracted the version that came to New York City via Europe, right? So this was not the Chinese variant that came to the West Coast. This was the European variant. And I followed her all the way through, and she actually did test positive for antibodies. Okay, this was in April, early May. She did test positive for antibodies. Okay, so she was ill before COVID was known to be an illness. And she then suffered through about 3-4 months of fatigue. She was a runner, so she was able to, you know, do 5-8 miles a day, and she could barely do any of her usual routine in the few weeks after she recovered. So easy fatigability, breathlessness, COVID fog, all of it in a very young woman. And so we're looking at about, so in October it was 884,000. So by now we're probably close to 1 million long COVID sufferers, probably 970,000 long COVID sufferers currently suffering from long COVID, not even those that recovered from long COVID. And we don't even know what is the cutoff point. Where do you say, okay, I had COVID fog for 3 months and now I don't have it anymore. I don't feel fatigue anymore. But how long did it last? Why? What was the internal healing process that led to the loss of those symptoms eventually? We don't have any studies on that, and we need it. because these are the patients that are going to cost the most. When you're dead, you don't cost anything except a funeral. When you recover from COVID with sequelae and comorbidity, your cost to the healthcare system, which is all that economists care about, economists and Republicans, then that's a big problem, because then they have to pay higher premiums. The economists and Republicans. I don't really care, but I do care about people suffering. So that has to be addressed. We need to know what causes long COVID, how to treat it, how to diagnose it, how to monitor it, and then how to, provide quality of life improvement to the point at which we can say that we can actually recover patients from long COVID, because we don't have any of that right now. We're only so focused on treating acute patients that no one is paying attention to these nearly 1 million people that are still suffering.
Hey, Sanjay?
Yeah.
Don asked, if you were COVID positive in January, would you know it from testing today?
Good question. January. So you would need a pretty sensitive antibody test that says that there is still detectable antibody to SARS-CoV-2 in your system. That would be an indication of exposure, plus the clinical history, obviously. I got sick, I feel terrible, I felt terrible for weeks. I recovered, I didn't feel well for a couple of months. I had fatigue, I couldn't walk up a flight of stairs without getting breathless. And now I feel better, but was it COVID? Well, that's a question I think Don is asking. You can get an antibody test, and then that would prove that you were exposed and recovered. Yes. Now the titer, the amount of circulating antibody to an infectious agent starts to decline, after about 3 to 6 months. So it becomes harder to detect it after the 6-month mark.
And I think the antibody tests are a little bit better than the ones I took back in May.
Yes.
May, was it?
Yeah.
Where I flushed $120 right down the toilet because someone suggested it might be a good idea.
I will take you and Leslie to an expensive dinner when I come down there next year to pay you back for that. Terry, go get an antibody test. We'll find out if you were exposed.
Yeah, that worked out great for me.
Sanjay, can you give the very sensitive test a name?
Yeah, LabCorp has the antibody, so it would be a circulating antibody test for SARS-CoV-2. Yeah. And it's available on the LabCorp and Quest website pages that will give you an indication. Again, after the 6-month mark, it's going to be unreliable.
LabCorp
or Quest Diagnostics. QUEST Diagnostics or LabCorp. Yep. Those are the two major labs that are running the antibody tests.
I had the Quest one in May.
Yeah, in May.
They've improved.
They have. Yeah, they have. Their initial tests were actually quite terrible. That a lot of people who had positive swab tests for the PCR tests, who had positive tests, were sick, recovered, and then went to Quest to determine whether they had effective circulating antibodies in May and June, especially May. The test showed negative. Okay, so but they corrected the issues with the sensitivity and specificity there. Yeah. But it was an expensive flop for $120 to be told. Wait, I was sick. I had a swab test. I was definitely sick, and now you're telling me I don't have antibodies. And people were questioning, well, is it causing some people to not have an antibody response? I mean, that's not how the body's. Anyway, it's more complicated than that. So let's just let it go.
I tried to explain to someone when something's that new,
Yeah.
You know what I mean?
It's gonna be-
Especially like when I took the test, the chances of it being that accurate would have to be low.
They were low.
I mean,
Yeah.
So I don't regret it, and you don't owe me a dinner. I'm just saying it's nice to know, you know, because it was this time last year where I got really like incredibly sick.
Yeah, you told me that. Yeah.
Yeah.
So, so topically, you know, I think I covered most of what I wanted to talk about on this update. The numbers speak for themselves; they're atrocious. The I think I covered the fact that um, if you want to be, I don't want to get COVID. Okay, why am I saying this? Because around the May time period, um, I, even with my heart condition, I thought, not knowing much about the disease or all of the comorbidities and sequelae that it could cause or the rapid death it could cause, um, I knew it was bad and it was killing people. But I felt like, okay, I'm in my 40s. If I get it, I'll probably get sick and get over it, you know, and I'll be okay, and then I won't have to worry about it anymore. It's amazing that in time I've started to revert. I'm not started. I've completely reversed my thinking. I don't want this to come anywhere near me or my house, my family, my children. And it is because the more I've learned about it, I understand how dangerous it really is. So there may be in society a sense of COVID fatigue, and I don't want to hear about it anymore. And if I get it, I'll get over it. Whatever, I can't stand this anymore. If I get it and get over it, then I won't have to worry about it anymore. But the problem is, if you get it and don't get over it, it could kill you, or it could kill one of your family members, or it can debilitate you for months, years, or the rest of your life. And the risk of you getting it now is the highest it's ever been. And if in fact we're seeing a new mutant, a new strain, similar to the one that emerged in the summer, and it's more transmissible, and that we'll only know how deadly it is in about 6 weeks from now, after we see the deaths that occur from this third wave. I don't want that strain either. I don't want anything to do with this thing. So as a result of that, line of thinking, which I hope to transmit to all of you, and I'm sure that I've done that tonight, because I have all of my reasonable, my people who've been with me for months and have been attentive to what I've been trying to tell you guys, and have been taking care of yourselves and your families. So if it sounds risky, don't do it. Lock yourself down as much as possible for the next 6 weeks. And if January 1st comes along and we're still in a shitstorm, lock yourself down for another 6 weeks. Because everybody on this call and everybody I know and everybody I love has to stay safe until whatever effective and safe vaccine is made available. And we do feel a sense of normalcy returning back to society. I don't feel like we're going to have any sense of that until after this new administration takes over. We have new public health mandates. We have real adults and experts in charge. We're able to lock down at a zip code level. We're able to use data appropriately, and all the states are forced to do it uniformly. I don't see anything good happening in the next 65 days. I do see some good happening thereafter. I do see a lot of good happening. And I want to be able to go to my sister's house, and I want to be able to take the kids and, Karen and the family on vacation next year. And so there's hope battling cynicism, but cynicism is winning right now. And I want you, hi, Terry. His middle name is Cynicism. But cynicism is winning right now. So I think that all of us need to take that very, very seriously. I just don't like the chances. I didn't fear going to the grocery store for all this time, but now I will be very cautious about how long I take there and how well I'm masked and all of that. Because the greater the prevalence, and let's go back to what we started, you know, if my county was below 10% all of this time, at our peak, we hit 6.8% back during the first wave. And then it dropped, and then all summer we were good. And now we are at 10.3% positivity in Luzerne County. That sucks. Okay. That merits school closure. And I don't want school to close when there's 6 weeks, less than 6 weeks left before the Christmas holiday for the boys, you know? But they're going into a very high risk environment, and they're coming home from a high risk environment now. Me going into the grocery store is the highest risk I have ever faced since the beginning, higher than the peak when the Northeast was a hotspot in the initial wave. That's how dangerous it is out there right now.
I feel the same where I am.
Yeah.
We're about 12%.
Yeah.
And our mountain opens up for skiing Friday.
Yeah, that's high. So you're going to have a lot of travelers inbound?
Yeah. I have 2 coming in, 2 physicians, a couple. One's a pathologist, the other's a dermatologist, and their daughter. And I think they're crazy, but whatever. You know.
Well, I'll see you next year with my kids, but not this year.
Okay.
Hey, Sanjay.
Yeah.
The story is from a family member up in Arkansas where they're actually keeping kids in school to finish the football season. And there'll be no shutdowns until football season is over. And they've had people come down, teachers come down sick, students come down sick, and there's no going backwards, you know, until they get past like football season, because that's the goddamn priority in their school is the football team. They're number 1 in their conference, so they can't shut down.
Yeah.
And like you were saying, I take a harsher view of what's coming. And like last time we met, and I said to buckle down because I saw nothing but bad was going to happen. It's happening now. Is bad. Worse is a couple weeks away.
Yes, it is.
And Christmas time is going to be a friggin' nightmare. Even with all the lockdowns, all the shutdowns, all that, the horse is out of the barn. And now we got to see how far it's going to run. Yeah,
good point. Very good point. Very good point. I would like to take a moment because this will be going on to YouTube. I would like very much to send a heartfelt fuck you to Dr. Scott Atlas. I think you need to get off of Twitter. You need to go back to whatever useless function you had at the Hoover Institute. You need to shut up, and you need to stop damaging the discourse of public health in this country. You're an embarrassment to the country. You are humiliating yourself and your institutions. You just, as someone that has protected, as someone that was raised by someone who took their reputation very seriously, my father, about how his patients thought of him and how he carried himself and what he said and how it affected every life. You know, having been raised by that person and having to try to do that myself and failed occasionally, but doing my best to help people and protect people. I hate you. I can't say it in stronger words. So, and I'm probably going to cut this clip out and tweet it directly to you. But you need to go away.
Amen, brother.
Hey, Sanjay, Sanjay and everyone here, his political posts from Twitter don't go onto his medical page. Now they go into Mrna Industries Facebook page. And I posted a link in chat in case anyone's curious what Dr. Sanjay Udoshi might say politically. that would be the place to find it.
Yes, thank you. Thank you very much. All right. We're at the end of our time almost, or I think we're a little over. Anyone has any pressing questions, anything I can help anyone with or address? We will be back on the third Tuesday in December. And we're going to hope to have John Daw with us for kind of a year-end wrap-up. Whatever is pressing and whatever I can bring you by then, I will. All questions are welcome to us. I will be back on Facebook next week, so I will try to, go through everything that was sent to me since I've not been able to respond. And then, what else? If there are any questions or topics, the scientific side I'm going to start focusing on more, so I'll be posting more to the clinical resource page. But then once I become active again, I'll start cranking up all of the output from the Biden transition and all the health experts that he's gathered. So we'll get in gear before the inauguration occurs. And until then, I just want you to all be safe. I love you all. Thank you for joining us.
Thank you, everyone.
All right.
Thank
See you
you.
next time. You're very welcome. See you next time. Take care. Good night.
Good night.
Good night.